Hello, so today I'm going to be discussing balancing the wound environment, ORC collagen silver, ORC dressings. My name is Kirsten Ryder. I'm from Integrated Medical Group. I'm a wound care and ostomy specialist out of Reading, Pennsylvania. Also presenting will be Dr. Robert Snyder. He's the Dean Professor and Director of Clinical Research at Barry University School of Podiatric Medicine, Miami Shores, Florida. So faculty disclosures, I'm a consultant and on the Speakers Bureau for 3M Acelity. Dr. Snyder is also a consultant for Redress. Program information provided by North American Center for Continuing Medical Education, LLC, and HMP Global Company. Also supported by an educational grant from 3M Healthcare Medical Solutions Division. Learning objectives for today are examine the clinical impact of ORC and addition of Silver-ORC in the wound environment, determine when to use ORC collagen Silver-ORC dressings and whom to use it, and examine via cases the application of ORC collagen Silver-ORC dressing. Let's take a look at the wound healing continuum. So non-healing wounds really kind of get caught up in this inflammatory phase. But when we look at the continuum itself, it's very time sensitive. It's an overlapping process. But when we get this bacterial contamination, it slows down or stalls the healing process and causes impaired healing. So, as clinicians, when we go in and we look at a wound, sometimes we really get caught up at, just visually what we see. And sometimes we can't see what's really going on underlying. So, taking cultures, looking at lab work can really tell you a lot as to what's going on, and kind of delving into the chart to see, what besides wound healing and at the wound surface is going on, but some of maybe the patient factors as well as, impeding the wound healing. So when we look at factors that impede healing, we really kind of need to look at the patient, okay? Age, okay? So as we age, our skin gets thinner and the body shows a decrease in inflammatory response, okay? Which can really impede, the way that we heal as we age. Smoking. We know smoking is a vasoconstrictor, so it doesn't allow, good blood flow to that area. Without good blood flow to, a wound that's trying to heal, it could be chronic and stagnant. And that's smoking and oxygen circulation kind of go hand in hand. Nutritional status. How many times have we told our patient, increase your protein intake, drink a lot of fluids? So those are the things that, we need to look at as well. If you're working in an acute care kind of setting, getting dietary involved, in an outpatient setting, maybe getting, a nutritional consult to make sure that the patients are eating appropriately. Stress. When we're under a lot of stress, our body doesn't focus on, the wound healing environment or, wounds in general. BMI, we don't just look at, high BMIs, but we also look and need to consider, our low BMIs as well. Medications, there are tons of medications that will impede the healing that, to be honest, there's, some that I didn't even think of, when, I started as a wound care clinician, but, some of those medications include immunosuppressants, corticosteroids, NSAIDs. Who would have thought NSAIDs? Most of our patients are on NSAIDs, but they can actually impede healing. Anticoagulants and anticonvulsants, which that was a new one to me when I learned about anticonvulsants. Immune status. What of our immune status? Is somebody who's chronically ill? Is it somebody who's going through, radiation or chemotherapy? Those patients who are really fragile flowers, as I would call them. And then chronic illnesses. So there's a lot of factors that we have to consider and really delve into a patient's chart as to, if there is a chronic wound and we're looking at it, we're just wondering, why will this wound not heal? These are some of the factors that we really need to take a look at and delve into that patient's chart. So now that I've talked about the patient factors, let's look at the wound healing factors themselves and what can impede the healing. So damaged matrix. If the matrix is damaged, we're going to have this wound that's stalled and is not healing. Exudate management. So we really need to take a look at, is our wound environment really wet or is it really dry? We have to maintain that moist wound healing environment. And the reason being is that exudate's main role is to facilitate the diffusion of growth and immune factors and the migration of cells across the wound bed, so it allows the wound to heal. Oxygen deficiency, bacterial bioburden and infection. So when we're looking at these wounds, we really need to, as clinicians, intervene and get rid of the bioburden that's in the wound base, so it allows the wounds to continue down that wound healing continuum like I spoke of earlier. High protease activity. So just keep this in the back of your mind, because I'm going to elaborate on the high protease activity later on in the presentation. Inflammatory environment. When there's that chronic inflammatory stage there's all these excess MMPs and proteases going into the wound bed, and it doesn't allow for the wound to heal because it goes into a chronic stage. Biofilms. So what are biofilms? They are complex structures of microbiomes having different bacterial colonies embedded into extracellular matrix. So what does that say? The biofilms, you actually have to go in and get rid of all these little structures, so that way you can get down to good tissue and you can start to allow the wound healing process to occur. Growth factor deficiency, non-migratory cells, and then sensate cells. So what does sensate cells mean? So it means that a cell ages and it stops dividing, but it does not die. So what that does is it can release these harmful substances that can cause inflammation and damage to nearby healthy cells. So then you get this chronic inflammatory state and a non-healing wound. So when we look at the inflammatory environment, what we want to look at is what the environment looks like, what's in that environment. So we have this ECM, we have the inflammatory cytokines, we have, the protease activity, we have, the reactive oxygen species, cell competence, and metabolic activity. So when you look at the other two columns, you have the chronic wound and the healing wound. The ECM in the healing wound is functional, so it's working the way it's supposed to work. We have low inflammatory cytokines, we have low protease activity, everything's low and the metabolic activity is high. And our chronic wounds, the thing I really want to point out is that the protease activity is increased or in excess. When we don't have that fine balance, when you look at the seesaw below, when growth factors are low, cell proliferation is low, things are low. When you have an increase in the negative factors, you have, the increase in bacterial bioburden, you have the increase in protease activity, and then you have these inflammatory cytokines. When your negative factors increase, that's when your wound becomes chronic. When your positive factors decrease, that's when you're also in a bad spot as far as your wound healing and a chronic wound environment. So when we look at how we're going to kickstart this cycle, we have, the degradation of the ECMs and the growth factors. Okay, so you have this damaged tissue. And then what happens is this bacterial protease and toxins are released. And then what happens is that kind of cycles into the inflammatory phase. So you have these cytokines and free radicals, which are, unstable and highly reactive scavengers in the body. And they seek out to replace missing electrons. And what happens is they cause damage to healthy cells, proteins, and DNA. So it shoots off this inflammatory phase. And then the inflammatory phase you have these excess proteases. So there's this huge imbalance, and this cycle continues and continues and continues. So how do we break that cycle that I talked about? So by breaking that cycle, we need to rebalance the wound environment. So when we look at doing that and really optimizing our wounds, we need to, one, maintain a moist wound environment. So how do we do that? We do that with, dressings that we have available on the market. We don't want them dry. We don't want them wet. We want them moist. So that way our cells can proliferate and move across the wound bed. We want to reduce that bioburden, so however you do that, you can do it by dressings, you can do it by debridement, but we have to reduce that bioburden, or that continual cycle is going to happen, as discussed earlier. And then once again, I keep throwing out this protease activity, proteases, what are they doing? What makes them chronic? Why does it make wound environment, a chronic environment? So we really need to lower those protease and free radical activity. But, that's something that, as clinicians, we really think about the wound environment and the moist wound healing. We really think about, decreasing the bioburden that's there, sometimes seen, sometimes unseen. But we haven't historically thought about, how do we lower that protease and free radical activity? So if we do those three things, we can stimulate the wound to move into a more wound healing environment instead of in that chronic stuck phase. So let's take a look at the evolution of wound dressings. So early on in the wound care days, in the 70s and 80s, our go-to dressings were, traditional dressings were gauze, sponges, normal saline moistened gauze into a wound bed, and then just cover it with a dry dressing. The problem with, the gauze dressings, the normal saline moistened dressings, is that when you remove them, it actually removes good tissue as well. But that's what we did for years. That's what we had. It healed our wounds, just maybe not as quickly. So then our mindset kind of changed, and we started thinking, all right, well, let's look at the environment itself, not just how long it's taking to heal these wounds, not how shortly, but the environment itself. So, the research started looking at, okay, now we need a moist wound healing environment. So we looked at different dressings that would do that. So we had our hydropolymers, our hydrocolloids, our collagen dressings, some of our gels, and then, our saline wet gauze is still there. But, we had to kind of weigh and measure moist wound healing. Is it dry? Is it wet? To really get that wound healing environment where we needed it to be. And then we started thinking, okay, so what's out there that would advance this, that wouldn't just heal our wounds and maintain a moist wound healing environment, but decrease length of time that it takes us for our wounds to heal. So then there was a lot of research done, and then our biopolymers came out, and our negative pressure wound therapy, and some of the pharmaceuticals that we use now, as well as, engineered tissue. And within this advanced therapies, we looked at, and what came about into fruition is our collagen ORC dressings, with and without silver. So let's look at the overview of proteases and why they are really important in chronic wounds. Proteases are protein degrading enzymes. There's two big categories, and they're the serine proteases as well as the MMPs, which I'm sure you've all heard of both. But what the serine proteases do, such as elastase, they can degrade, like I kind of alluded to earlier, growth factors, and therefore reduces the bioactivity. And MMPs, which they can break down proteins in the wound. So collectively, like I said, they can degrade soft tissue components of the extracellular matrix. So normally they are controlled at a tissue level by natural inhibitors, and they are synthesized and stored as inactive enzymes. So let's get into what the role of the proteases wound healing is. So their formation and degradation of fibrin clots, They act on cleansing the wound of bacteria. So they go in there and they actually eat away and degrade bacteria that's in the wound base. The migration of inflammatory cells. So they help with those chronic inflammatory cells that are in there, alleviate them. They debride wound of, ECM fragments, or what we call autolytically debride the wound base, you can consider it. Cell migration of keratinocytes and epithelialization, migration and stimulation of fibroblasts, and selected growth factor activation. So in a normal wound healing, proteases break down damaged ECM proteins and foreign materials so that new tissue can form and wound closure can occur in an orderly fashion. So when we look at this diagram, okay, proteases in chronic wounds. So in the normal course of wound healing, there is a rapid initial increase of protease levels. In the levels, they peak at about approximately 3 days and start to reduce about 5 days. In a non-healing wound, proteases reach higher levels than in healing wounds, but they persist for longer. And this results in a highly destructive wound environment. So what this slide shows you is that as proteases activity increases, the probability of a wound to heal actually decreases, and then it becomes a chronic wound that has an inflammatory process that continues. So when we look at the clinical evidence on proteases, there's more than 30 studies out there that shows that proteases in excess in chronic non-healing wounds, in excess of proteases have a negative impact on wound healing. So let's look at the evidence for collagen ORC dressings. So when we think of collagen, collagen is a family of proteins. There are greater than 20 different collagen types known. They are found in groups of animals and highly conserved between species. It's the most abundant protein in animals and the most abundant in human beings. When we think of collagen in the skin, there's more than a quarter of our total protein in our bodies is collagen. It's a major component of the soft tissue, including the dermis. So collagen actually forms a scaffold to provide strength and structure. So let's talk about the benefits of collagen. So collagen, it's a naturally occurring material, so the body won't reject it. It is a component of our tissues, and it's recognized by all tissue cells. So what that means is it enhances the deposition of new collagen fibers, and it also is a substrate for cellular adhesion and migration. The great thing is it's bioabsorbable and biodegradable. So what exactly does that mean from a wound care clinician? So as a wound care clinician, when we use collagen such as Promogran and Prisma, we really need to change our mindset a bit, because we're so used to when we do dressings that what we put in, we take out. Well, collagen is bioabsorbable. So when you put it in a wound and you go to change the dressing at the next dressing change, you're not going to be removing the collagen because it's bioabsorbable. So the body absorbed it. So you won't see that. So it's a bit of a mindset that we need to change as clinicians when we're using this product. And we also need to explain to our patients that, hey, I'm going to put this in the wound, but you might not see it, or you won't see it next time the dressings change because the body absorbed it and is, building that scaffolding for new cells to grow. And then it also lowers the inflammatory and antigenic response. And then it also has hemostatic properties, so it reduces surface bleeding. So think about those patients who are in the OR and have a little surface bleeding, and the clinician or surgeon uses cauterization and they over cauterize. So what happens is when they over cauterize, we actually have to take 3 steps back by removing that cauterized tissue to get to healthy tissue before we can move 10 steps forward. So instead of doing cauterization on those little surface bleeders, we can actually put the chromogram or the prisma in that place, and it'll help reduce that surface bleeding so we can immediately start moving forward instead of, taking 2 steps back before going forward. And then it also acts as a substrate for excessive MMPs. ORC, oxidized regenerated cellulose. So cellulose is the most abundant material on the surface of the earth. Cellulose is mainly obtained through wood pulp and cotton. There is a chemical modification of cellulose that has very different properties, but oxidizing makes cellulose biodegradable, i.e. the ORC. It degrades in a predictable and consistent manner, and degradation occurs by fluid absorption and subsequent gelling. And the really interesting thing is when ORC degrades to sugars, it makes it into glucose and glucuronic acid when it's wet. So just keep that in mind as we move forward in the next slide. So what are the benefits? So when the ORC degrades to sugars, like I said, the glucose and glucuronic acid, it actually gives energy and nutrients to the wound. ORC also lowers the pH as it breaks down, so it helps control the bacterial burden in the wound bed. And then also, like I had said before, it has hemostatic properties, so it helps reduce the surface bleeding if you have a wound that has, minor bleeding or of serosanguine fluid. When we look at the published data, there's published in vitro studies that show that the combination of collagen, ORC, and silver can inactivate proteases, can reduce bacterial bioburden, and has no detrimental effects on the growth factors or cell growth. And overall, the studies have showed that it does show improved clinical outcomes if implemented quicker or more frequently. So when we look at this slide and how ORC reduces elastase activity in vitro, so oxidized regenerated cellulose modifies the wound environment by binding and inactivating excess levels of elastase, which you can see here in this slide. So collagen with ORC compared to just collagen only, you can see how there was 100% reduction in elastase with the ORC, and just collagen alone without ORC only decreased it by 30%. So looking at some of the published studies, you will see this one in particular was on venous leg ulcers. And what this shows is collagen ORC compared to a control. So at day 0, okay, the number of elastase levels or your proteases, elastase is a protease, is relatively the same. But at day 5, you can see there's a huge reduction in the amount of elastase levels in the collagen ORC compared to the control. And like I had said previously, if there's an overabundance of proteases that remain in the wound bed, you're going to end up with a chronic wound that's in a chronic, inflammatory state. So the sooner that we can reduce the number of proteases, i.e. elastase, in the wound bed, the quicker we're going to get into that wound healing continuum and have optimal and better outcomes. So you can see here that day 5 drastically decreases and then steadily kind of decreases over the period of 56 days, where the control pretty much remains the same from the time the dressing is initiated until day 56. So when we look at collagen ORC silver, the dressing, when you look at this diagram, the ability of ORC collagen containing the silver to reduce bioburden and retain dermal cell viability is significant. And what this slide is going to show you is that collagen ORC with silver delivers the benefits of silver without harming cell growth. So if you look at the schematic there in the diagram, what it's showing you is that over a period of time, the collagen ORC with silver will beat back bacteria, the MRSA, the E. coli, the streptococcal, the VRE, the Pseudomonas. It'll continually over time beat back those bacterial levels and decrease those bacterial levels without causing any undue harm to any good cell growth or cells that are already in the wound base. So this is an interesting slide because they did this under a microscope, and what it shows you in this slide is that on the left you can see that there's growing cells and what normal growing cells look like, and then the one right next to it is what dead cells look like. So when you compare the collagen ORC with silver to growing cells, they look the exact same, okay? And compared to other dressings with silver in them, they look like the dead cells. And of course, we don't want dead cells. We want nice, healthy, growing cells. So it mimics collagen with ORC and silver, mimics what our normal growing cells look like. So Guttrup did a study in the reduction in the area of wounds and diabetic foot ulcers, and what that showed is that collagen ORC significantly reduced the bacterial burden in the wound base over 100% compared to the control that was 33%. So when we look at this slide, what this really shows you is that the sooner that we implement the collagen ORC with silver, the quicker our wounds are to heal. You can see in less than 6 months, 73% of those wounds went on to heal with the initiation. The longer you wait, the less that you get healing time, and the more potential it is for these wounds to go into a chronic non-healing state. So in summary, there's tons of publications out there, in vitro, in vivo, just, clinically in patients, hands-on, that demonstrates that the sooner that we initiate collagen with ORC and collagen ORC with silver, the better outcomes and the quicker positive outcomes the patient's going to have by decreasing that protease elastase activity. Collagen ORC, so it is clinically effective in treating chronic wounds, as it has been shown throughout the presentation. Provides an optimal environment which promotes wound healing. How does it provide that optimal wound environment? Well, you have your silver that helps beat back any kind of bacterial bioburden that's in the wound base. It has the ORC, which breaks down into your simple sugars that provides nutrients to the wound base, as well as, once again, it's going to decrease that protease activity. So therefore, it's not going to degrade the good stuff that's in the ECM, and therefore allowing the wound to move into a chronic stage, if it gets there, into an optimal wound healing environment. And once again, like I had said earlier, if it's implemented sooner and adopted earlier, you're going to have significantly improved outcomes and faster outcomes. And then collagen ORC, what are the benefits? It has silver in, and it protects against infection. So now I'm going to turn the presentation over to Dr. Snyder. He's going to go through some case analyses on how collagen ORC with silver can be utilized to benefit and provide good clinical outcomes.
Well, thank you very much for that elucidating presentation. My name is Dr. Robert Snyder. I'm Dean and Professor of Clinical Research at Barry University School of Podiatric Medicine in Miami Shores, Florida. My topic today is really to look at some case studies based on some of the information that you had in the previous lecture. So here is my first case. This is a patient with diabetes who presents with a very common problem that we often see. It's a neuropathic ulcer in an individual with diabetes. This is a 55-year-old diabetic male with an ulceration on the bottom of the right foot that's been present for approximately 4 weeks. The patient has palpable pedal pulses at a toe brachial index of 0.9. There was no bone exposed, and there was a negative probe to bone test, which usually certainly lowers your suspicion for underlying osteomyelitis. Previous treatment really consisted of saline gauze and a surgical shoe. The patient had weekly debridements, and the wound actually initially improved, despite the fact that offloading may have not been optimal in this case. However, now is in a situation where it has stagnated. So what would you do here? Would you continue with local therapy? Would you call for a vascular consult? Would you actually hospitalize this patient because of the duration of the wound? Or, of course, would you consider some type of an advanced therapy and think about augmenting offloading? So give it some thought, just think about it for a moment. And certainly this is a very common scenario that we see in our practices every day. So what I did here is the wound began to improve dramatically with an advanced therapy and augmentation of offloading. Of course, a surgical shoe, although it is very commonly used to offload diabetic foot ulcers, it really is likely the least effective in doing so. So in this particular case, what we did was we utilized Prisma for approximately 2 weeks. And then at that point, we moved on to Promogram. Now, what's really very interesting about this dynamic is the fact that Prisma can actually be used throughout the entire healing trajectory. Prisma has a very low level of silver, 3 parts per million, so it does not create cytotoxicity. Also, it is double density, so it likely will last longer on the wound. So certainly you could use or could have used Prisma to closure. And in this case, we continued with weekly debridement, and I also used a total contact cast, which clearly is the most effective way of offloading these neuropathic ulcerations. The patient had a toe brachial index, which was well within the normal limits. So now we're left with this situation. What do we do now? Well, in this case, clearly moist wound healing was appropriate, and I switched to a cam walker or a walking boot, which we find that in very many cases can be as effective as a total contact cast, particularly if you use it as an instant total contact cast where you actually wrap the cam walker in Coban or some similar product. And of course, at this time, the wound went on to completely reepithelialize. This is another case, a very interesting case, I believe. Is a person I've seen for many years, a 63-year-old male who presented with edema and a copiously draining wound at the lateral aspect of the right lower leg. The patient had a history of profound venous insufficiency, had had multiple ulcerations in the past, but this looked a little different because there was clearly some significant hyperemia and edema. Additionally, there was significant drainage at the dressing site, and there was a greenish tinge to that drainage. So what would you do here? Would you apply a foam dressing and a multi-layered compression drap in this case? Would you just debride the wound and perhaps take a culture and begin a broad spectrum oral antibiotic treatment as well as a topical silver therapy? May you obtain an urgent vascular consult over concerns regarding ischemia? Or would you immediately hospitalize this patient for intravenous antibiotics and an urgent operating room debridement? I must also tell you that the patient did have palpable pedal pulses and was not diabetic. So in this case, after a debridement, a culture was taken and the patient was started on an empiric course of oral antibiotics, and we began using a topical silver along with a calcium alginate dressing. The ulcer really began to improve, and the culture showed a relatively high growth of Staph aureus. So what are you going to do? Are you going to continue a total of 10 days of antibiotics, but perhaps refrain from multi-layered compression? Will you continue antibiotics for a total of 10 days along with a silver and calcium alginate dressing and perhaps at this point begin a multi-layered compression? Would you apply a total contact cast? Or would you use another choice? Let's think about it. So in this case, we did use antibiotics for a total of 10 days, along with a silver calcium alginate dressing. And in this case, we did decide to use multi-layered compression because we felt that the patient's cellulitis had dramatically improved. Now we're left with this. We have some beefy red granulation tissue. The edema has decreased. The hyperemia is dramatically better. Now what's the plan? So in this particular case, we used Prisma and a multi-layered compression dressing for 2 weeks. Remember, Prisma is a double density. It contains both collagen and silver, but silver is seen at a very low level, so it is not cytotoxic, and it can be used to closure. And of course, ultimately, we used a TL dressing and weekly multi-layered compression until the area was healed. So here's case 3. This is a 53-year-old African-American male with insulin-dependent diabetes. The patient has non-palpable pedal pulses and his right foot was extraordinarily cool. He had a foul-smelling wound at the right hallux with severe pain, despite the fact that he had diabetic neuropathy. This is never a good sign. Usually when you have pain in an otherwise painless foot, this is often indicative of an underlying abscess or infection. The duration was only 5 days and the patient had no previous treatment, but I suspect that this had been present for considerably longer. The patient in this case was febrile with a white count of 18,000. So what would you do here? Would you order an angiogram and a vascular consult before any local surgical intervention was performed? Could you take the patient to the operating room urgently for an extensive debridement prior to even any vascular intervention, or would you just treat locally with wound debridement and topical antiseptics? Give it some thought. So what we did here is, after successful endovascular intervention, the patient had undergone a transmetatarsal amputation. However, the patient had significant tissue loss at the original site of surgery, making closure very, very challenging. So this is actually what it looked like after the transmetatarsal amputation was performed, and we used a cadaveric allograft to cover the defect that was open, and those are staples that you see surrounding that cadaveric allograft. This is just another view of the same patient. So we had the patient on intravenous antibiotics for 6 weeks, and of course, we used a multidisciplinary approach. But now you're stuck with a very difficult and challenging scenario. We have a very large defect, and of course, that cadaveric allograft is not permanent. So now what will you do? Well, in this case, the patient benefited from 2 weeks of negative pressure wound therapy. However, the wound still remained opened. So what we did here was we used collagen, ORC, and silver, Prisma. And again, ultimately just went to Promogran. But to reiterate, you can use Prisma to closure. Here's another case of a 68-year-old Haitian male. Patient has what looks like a very significant infection, weakly palpable pedal pulses, an abnormal ABI. The patient has a necrotic right great toe, severe pain despite the fact that there is neuropathy, and of course, again, never a good sign. The patient has crepitus in this case. What does that mean? Well, it's very, very likely that the patient has gas in the tissue. Despite this, the patient's white count and CRP was within normal limits, something that we very often see in patients with diabetes. They're immunocompromised, so their infective process and their systemic symptoms lag behind what we are actually seeing clinically. And the patient was also afebrile, and again, duration 5 days. This is what the X-ray looked like. And of course, what you can plainly see dorsally is that the patient has gas bubbling up in the tissue. So what would you do in this case? Would you order an urgent interventional radiology consult prior to any surgical intervention? Would you do an urgent operating room debridement, including a partial first-ray amputation? Would you hospitalize the patient for intravenous antibiotics and wait until the infection begins to resolve before you think about surgery? Or the patient has no constitutional symptoms, so perhaps you could just culture the wound and treat empirically on an outpatient basis with oral antibiotics and local wound care. So what would you do? Well, here's what we did. We took the patient urgently to the operating room. Now, whenever possible, we like to have vascular intervention before we do any kind of invasive procedures. But there are instances where we don't have that luxury. And these are the emergent cases where you really have to save the patient's limb and the patient's life. So this is exactly what we did. And this is what we were left with at the end of the day. So the patient had undergone successful endovascular intervention after the procedure had been performed, and now fortunately had a 3-vessel runoff. And of course, you were using a multidisciplinary approach. What we did here, and what likely would be the logical choice, would be negative pressure wound therapy. What would you have done? So the patient did have 3 weeks of negative pressure wound therapy, and we did use a non-adherent silicone dressing as an interface. Why do we do that? Because with negative pressure, sometimes you can have an ingrowth of the granulation tissue into the foam. We also want to make certain that that foam can be easily removed. The patient also required 6 weeks of intravenous antibiotics, and the patient was doing quite well. But the patient was still exhibiting copious drainage and increased wound bioburden. So what's next? Well, in this particular case, we used the calcium alginate silver dressing for 2 weeks, and then we followed this with Prisma for 2 weeks. And again, the reason why we used a heavier silver dressing was because the patient did have significant wound bioburden. We wanted to try to eliminate that to the extent possible, but again, as quickly as possible, transitioned to Prisma. So now we're left with this. What are you going to do now? Well, we actually just used moist wound healing to closure. In this case, we used a hydrogel and foam, and the patient went on to heal. So the final case, case 5, is a very interesting one. This is an individual who worked for the federal government, who actually traveled all over the world giving talks to federal employees on some very high-level topics. In fact, when I asked him at one point what he had done, he said he could tell me, but then he would have to kill me. So this was a very important high-level individual who unfortunately had insulin-dependent diabetes for a very long period of time, and had also been the recipient of a kidney and pancreas transplant. This is a 67-year-old white male that had insulin-dependent diabetes mellitus. He did have a history initially of a very small ulceration under the first metatarsal head. And in fact, we had seen him right before he had gone on his business trip, and we kind of advised him not only to be cautious, but likely to cancel that trip. We just felt it was a very ominous sign for him in light of his previous history. But of course, he decided to make the trip anyway. And when he returned from his business trip, he had advised us that he had done an extensive amount of walking and was sitting in airplanes and airports for very long periods of time. So of course, now he presents with this very, very serious problem, this blue toe with significant necrosis, drainage. The area was excruciatingly painful, despite the fact that the patient did have diabetic neuropathy. And I wanted to make a point of that because when you think in terms of diabetes and sensory deficits, very often these patients will have infections, but they will not have pain. So when they do present with pain in an otherwise painless foot, that certainly could be a very significant sign for the possibility of underlying abscess and or infection. Now, fortunately, the patient, despite the fact that he had neuropathy, both motor, sensory, and autonomic, he did have a history of a recent distal bypass surgery. And when we had evaluated him with a chairside Doppler, and we also listened to his angiosomes, we realized that not only was the bypass patent, but we could really hear all of his 6 angiosomes within his foot. Surgery in this particular case was considered emergent. So in this case, what would you do? Would you follow my lead and take the patient to the operating room? Would you treat with a topical therapy and antibiotics and just kind of treat the patient inpatient, but just watch the patient carefully? So think about this, because again, a serious problem indeed. So what we did here was an opened transmetatarsal amputation. Why didn't we close it? Because the patient had pus behind that area. And of course, you can see very clearly that the base of that first ray is still very evident. Now, over this area, we placed cadaveric allograft and we fenestrated it. In other words, we put it through a mesher 1.5 to 1 so that we could actually eventually cover this entire area to try to keep the area moist and also protect the underlying bone. Now, very often what we do in this case is we use negative pressure wound therapy, and we use it at 125 millimeters of mercury. And in this particular case, we applied it for 2 weeks. Once we felt that it was safe and the infection was under control, we did order an angiogram, which fortunately for this patient had revealed a 3-vessel runoff, and the vascularity really was deemed appropriate to support healing. So I truly believe in this case, we had done the right thing for this patient. And I'm glad to say that the patient did go on to heal that transmetatarsal amputation until he went on another trip. So of course, we did use negative pressure wound therapy in this case in conjunction with adaptic touch. So unfortunately, even though the patient did heal the TMA that we had performed, he did go on another trip and then returned with this severe necrotic area and infection secondary to not only lack of adherence, because he was just really not following our directions, but he continued to wear a tight shoe. Now, why is that so important? Because patients with diabetes, when they're utilizing tight shoe gear, very often feel good wearing a shoe that feels snug, when in actuality, it's creating a devastating scenario by opening up ulcerations in various places of that extremity. So of course, in this particular case, emergent surgery was undertaken and all necrotic tissue was removed. So after that is done, what do you think we should do? Well, in this case, this is what we had. Status post-debridement. We were seeing the patient on a regular basis. We were debriding on a regular basis. We were hopeful that all vital structures would ultimately be covered. And in this particular case, we used an acellular dermal matrix. And this is very, very common in our practice because it will keep the area moist. And it almost seems, at least from the body's point of view, it almost tricks the body to believe that there is a skin graft there, when in actuality, it is something that will ultimately become necrosis and slough away. So this is what we were left with, a 2-week status post-dermal matrix application. We used adaptic touch and we used negative pressure wound therapy. Again, very, very effective in this case. And it looked like things were going in the right direction. So what would you do next? So in this case, we actually applied a split thickness skin graft. Of course, we meshed it at 1.5 to 1. The graft was taken from the thigh. And we also used negative pressure wound therapy at 75 millimeters of mercury for 5 days. This is usually what is required and has really become the standard of care for application of split thickness skin grafts. And of course, it was very important in this case for us to use adaptic touch as an interface between the graft itself and the foam, because we did not want there to be a problem when the foam was removed. But what I really want you to pay attention to here is what the donor site looks like. This is very commonly seen, and what we're using here is Xeroform. Xeroform contains bismuth. Now, it does have some antibacterial effect, but the whole idea behind using it on a donor site is actually to allow it to dry out and almost begins to look like a potato chip and then basically just sloughs away. And unfortunately, particularly with patients who have diabetes, we wind up in situations where the graft itself doesn't hurt because they have a neuropathic foot. But what is very painful for them is the donor site, in this case, at the level of the thigh. So I have some good news to share, and that's the fact that we may have a solution that could theoretically and actually replace these types of dressings. And this is the utilization of Prisma. Now, why would we use Prisma in a situation where you have an acute wound? Well, you have collagen, you have silver, and what's really important here is you're allowing this dressing to dissolve, so you don't really have to remove it, so it is not painful to take off. This dressing is usually left on for anywhere between 3 and 7 days. We have also found a substantial decrease in the amount of pain that individuals have from this donor site. And when the dressing is ultimately removed, in a large percentage of cases, this donor site is normally reepithelialized. So before we wrap up, there are always a couple of questions that bubble up that I feel should be answered at this time. The first is the positive probe to bone test. How accurate is this test? Well, for those of you who have not been familiar with this methodology, what we do is we take a probe and we fish it down to see whether or not we can actually touch the bone. And there was some interesting work a number of years ago done by Grayson and colleagues that basically indicated that in greater than probably 88 or 89% of the time, if you could probe to bone, there was a very strong likelihood that the patient had an underlying osteomyelitis. Then several years later, Larry Lavery and colleagues looked at the same issue, but looked at the negative predictive value if you could not probe to bone. And he found that there was a very, very large predictive value, but a very low predictive value if you could probe to bone. So again, there's this kind of dichotomy, if you will, in the literature. So what does that mean? What it basically tells us is that this should really be raising your level of suspicion, particularly in diabetic patients. Why? Because patients who have underlying osteomyelitis, very often their clinical symptoms will lag behind what we're seeing radiologically. So if you take an x-ray of that patient, even if you can probe to bone, more often than not, you will not see radiologic change. It can last anywhere from 2 weeks, 4 weeks, 6 weeks, 8 weeks behind what we're seeing clinically. So certainly this is something you need to keep in mind. One other thing to keep really in the forefront of your mind is the fact that diabetic patients very often will not mount a physiologic response relative to constitutional symptoms. So don't be fooled. If you have what appears to be a serious case, but you take the patient's temperature and they're afebrile, you do some blood work and their white count is normal, their CRP is normal, it doesn't necessarily mean that they don't have an infection which is raging out of control. So certainly keep that in mind. Make sure you're keeping a very close eye on the patient's vascularity. And also remember that just because you feel or do not feel a pedal pulse in a patient with diabetes does not necessarily mean that you may or may not have adequate vascularity to support healing. Take those next steps. And of course, whenever possible, get a vascular consult. So thank you very much for your time.